Today we are going to talk about membranous nephropathy. To understand membranous nephropathy, we need to understand the structure of glomerulus. The glomerulus is a structure situated at the beginning of a nephron. So it is composed of mainly two structures, a tuft of capillary which is known as the glomerular capillaries, and surrounding it is a cup-shaped structure known as the Bowman's capsule. Bowman's capsule is an epithelial structure which is composed of two layers of epithelium, the outer layer known as the parietal layer and the inner layer, the visceral layer, which contains finger-like projections called podocytes. The tuft of capillaries, glomerular capillaries, have an afferent arteriole which brings blood to the tuft of capillaries and efferent arterioles which take blood away from the capillaries. There is also the mesengium, which contains the mesangial cells. What is the purpose? The purpose of the glomerulus is ultrafiltration of blood. The filtration of blood occurs through a barrier called the filtration barrier, which is composed of three layers. Filtration barrier allows small molecules to pass from the blood vessels into the nephron but prevents large molecules from entering. It first passes through the endothelial layer of glomerular capillary, which contains pores called fenestrae. Then it crosses through the glomerular basement membrane. Then it crosses through the visceral epithelium containing podocytes, which has slit diaphragms in them, and then directly into the nephron. This entire barrier is negatively charged. Only small and cationic molecules can pass through. So what happens in membranous nephropathy? In membranous nephropathy, antibody against the podocyte surface antigen phospholipase A2 receptor is created. As these molecules are small and cationic, they pass through the endothelium, the glomerular basement membrane, and are deposited into the subepithelial layer, causing damaged podocyte. These damaged podocytes then allow passage of small and large molecules, for example, protein. This results in massive proteinuria, which leads to hypoalbuminemia in the blood, which results in presentations of nephrotic syndrome. Loss of protein results in loss of inhibitors of coagulation such as protein C, protein S, antithrombin 3, which results in hypercoagulability. Membranous nephropathy is the commonest cause of adult idiopathic nephrotic syndrome. It is associated with drugs such as NSAIDs, penicillamine, hepatitis B virus, malignancy, and lupus nephritis class 5. Renal biopsy with histopathology shows thickening of the glomerular basement membrane. Direct immunofluorescence shows subepithelial granular IgG deposition. Thickening of glomerular basement membrane around the subepithelial deposit causes a spike-like protrusion, resulting in a spike and dome appearance in electron microscopy. Patients with membranous nephropathy are given ACE or ARB to reduce proteinuria. Idiopathic patients are given steroid and immunosuppression with cyclophosphamide and rituximab. One-third of the patients progressed to ESRD, one-third spontaneously remit, one-third remained stable. Follow final diagnosis for more content.